This is Sean McAllister for Anesthesia 4101, Assignment 5, Anesthetic Care Plan. The plan procedure today is a open repair of an infrarenal abdominal aortic aneurysm that took place last week. The patient demographics are 72-year-old male, 177 centimeters, 78 kilos, giving a BMI of 25, with no known allergies. Past medical history, GERD, hypertension, hyperlipidemia, hard of hearing, osteoarthritis in both wrists bilaterally. How the AAA was found, the patient presented to his GP in August of this year with unexplained mild abdominal pain. Blood work revealed unexplained borderline anemia. The patient went for a CT abdomen, which incidentally revealed a large occult 8 by 8 centimeter infrarenal abdominal aortic aneurysm, and he was subsequently referred to vascular surgery here in Prince George. The patient has never had a general anesthetic before. In 2018, he had a colonoscopy. Other than that, his family history is negative for malignant hypothermia. Preoperatively, the day of surgery, CNS, the patient presents alert and orientated. He was decidedly nervous, outwardly nervous. He was sitting up in a chair. He was able to answer and ask questions appropriately. He had no history of strokes, TIAs, falls, fainting spells, anything like that. Cardiovascular-wise, he had equal bilateral radial pulses, good cap refill. He had a strong S1, S2. With no murmurs. He has no history of angina or coronary artery disease, and is easily able to walk more than 2 kilometers a day. Respiratory wise, he has no history of asthma or COPD exacerbations. He quit smoking in 1994 with a 50 pack year history. No recent respiratory tract infections or pneumonias. He's received both COVID-19 vaccines, his pneumococcal vaccine, and as previously mentioned, he has greater than 4 METs exercise tolerance. GIG is unremarkable. Endocrine is unremarkable. His current medications are ASA 81 milligrams daily, Ramipril 2.5 milligrams BID, and rosuvastatin 20 milligrams QD. Preoperative vitals in surgical daycare, heart rate of 86 beats per minute and normal sinus rhythm. BP of 135 over 86, rest rate 16 to 20 as he's speaking with us. He was setting 97% on room air and a temp of 36. The patient's airway assessment revealed full dentition with no loose teeth, class 1 malumpati with a mouth opening of greater than 3 finger breadths. Adequate thyromental distance and mandibular protrusion. Was a grade A. He had reassuring cervical flexion and extension. Overall, seemed like a very reassuring airway. Preoperative labs from the day before revealed a hemoglobin of 119. Not particularly robust, but not low enough to require preoperative transfusion or iron replacement therapy. Biochemistry wise, his electrolytes all within normal range, just normal sugar, and renal function was normal as well. ASA classification, this is an ASA class 4 patient. He presents for surgery with severe systemic disease. He has an 8 by 8 centimeter infrarenal AAA that poses a constant threat to life. I believe AAA patients are booked for open repair when the calculated risk of aneurysm rupture equals that or more of the mortality risk of the surgery, which I believe is 5%. For our anesthetic plan for this gentleman, so the primary anesthetic goals for this procedure are to preserve myocardial, renal, pulmonary, and cerebral perfusion, maintain adequate intravascular volume and cardiac output, anticipate surgical maneuvers that will affect blood pressure and blood volume, specifically cross-clamping, and as well as to control blood pressure to minimize risk of rupture of the aneurysm or the graft. With regards to fluid management, this is going to be an open surgical approach. It's transperitoneal with a midline abdominal incision. Therefore, I anticipate severe surgical losses intraoperatively. Preoperatively, I was able to place 16 gauge with some lidocaine infiltration in the distal left forearm. Preoperatively, we also spoke with the patient about the placement of a triple lumen CVL after he goes to sleep or post-induction. The patient began fasting at 2000 the night prior with surgical start time scheduled for around 8 a.m. So it's about a 12-hour fasting period. Based on his body weight of 78 kilos and using the 4-2-1 rule, that gives him a baseline fluid requirement of 118 mils an hour. With a 12-hour fasting, given his basal fluid requirements, he has a deficit of 1,416 mils preoperatively. Also taking into account the anticipated severe surgical losses at 8 mils per kilo per hour times his body weight of 78, we could easily anticipate fluid loss, insensible fluid losses of about 624 mils per hour intraoperatively. The patient is cross-matched. He's A positive. He has 4 units of blood on hold in the blood bank. Our plan is to prime and place level 1 rapid transfuser just outside the room. I'm also going to use the Ranger fluid warming device for maintenance IV fluid warming to aid in maintaining normothermia intraoperatively. Next, talking about blood volume and most importantly maximum allowable blood loss for this type of open and extensive vascular surgery. His estimated blood volume for a 78 kilo male is 70 mils per kilo, so he has an estimated blood volume of 5,460 mils. He had a pre-op hemoglobin of 119. Although he does not have any cardiac history, I would still go with a transfusion threshold of hemoglobin of 80, which gives us a maximum allowable blood loss of 1,789 mils. Monitoring for this procedure will include 5-lead ECG. He'll have an arterial line. We're going to utilize the flow track, which will be placed prior to induction. SpO2 monitoring, temperature monitoring, SED line, Foley, and CVP off of the distal lumen of the CVL. This procedure is also quite painful. Open abdominal incision and epidural will be most beneficial postoperatively. Preoperatively, we talked to the patient about epidural placement. He was very amenable to epidural placement and there was no clinical contraindications. We'll aim to place the epidural around T9, T10 to cover the dermatomes of the midline abdominal incision and also to avoid any negative impact on the cardiac accelerator fibers, which are located from T1 to around T6. My airway management plan, as he presents with a reassuring airway, I plan for direct laryngoscopy with a size 8 endotracheal tube. Given 78 kilos, I had a size 5 LMA immediately available as backup if I was unable to bag mass ventilate the patient. Induction plan was midazolam 2 milligrams once the patient entered the room for anxiolysis and to help with anxiolysis and management of epidural insertion in the art line. Fentanyl, we used a 200 mics IV. Propofol, we gave 150 milligrams IV. And rocuronium, we gave 100 milligrams IV. Post-induction as well, we also gave Epimorph 2.5 milligrams via the epidural catheter and gave 2 grams ANES for surgical antibiotic prophylaxis, which will redose every 4 hours. Maintenance of this procedure is primarily volatile anesthetics. Sevoflurane is what we used. aiming for a MAC of 0.9 to 1.2 as tolerated hemodynamically. As this is quite a very painful procedure, adequate surgical anesthesia is a must. The epidural will also aid in surgical anesthesia. We ran an epidural infusion of fentanyl 2 mics and bupivacaine of 0.1% at 6 mils an hour. Intraoperative considerations for this procedure are the avoidance of myocardial ischemia, minimizing hypertension, most specifically with cross-clamping of the aorta, the descending aorta, prevention of stroke, hemorrhage, coagulopathy, hypothermia, and organ ischemia, particularly renal ischemia. The emergence phase, as the procedure comes to an end, in this type of patient, decide whether we were going to extubate or keep him intubated and transferred to ICU. And for most extensive vascular procedures, it depends on several factors. So is the aneurysm grafting stable and hemostatic? The patient's fluid and blood volume status, what are their hemoglobin levels? Are they third spacing? Are they edematous? Do they need more fluid resuscitation? What's the patient's hemodynamic status? Are they requiring vasopressors and or inotropes? What are the doses required? Their metabolic profile, is it within acceptable normal range? Do they have acceptable ABGs? And if you plan to emerge the patient, when you emerge them, do they wake appropriately, or is there delayed awakening? In the emergence phase prior to extubation, obviously we want to minimize post-op nausea, vomiting. We gave ondansetron 4 milligrams IV, as well as 8 milligrams of dexamethasone towards the beginning of the procedure. Prior to the surgery ending, we did give another dose of rocuronium about 55 minutes prior to surgical closure. We assessed train of 4, and the patient had 2 of 4. So we decided to use 200 milligrams of Scamodex to ensure full reversal prior to extubation. The postoperative care for this patient, again, if they were not extubatable, they would transfer to ICU ventilated for continued management. If he is extubatable, which he was, he went to a fully monitored PACU bed, and then he would proceed to a surgical step down. Most importantly, postoperatively, is to keep the blood pressure under close control to decrease the possibility of bleeding from the surgical graft site. In such an extensive open procedure, there is a very high risk for respiratory failure postoperatively, from splinting, atelectasis, delirium, delayed mobilization. There's also risk of renal failure and myocardial ischemia in the postoperative course for this type of patient. His post-op pain management strategies, as we touched on earlier, he had the epidural at T9, T10, and he continued to run the epidural infusion of fentanyl and bupivacaine at 6 mils an hour. He will also have hydromorph 0.2 to 0.4 milligrams IV Q30 as breakthrough, no more than 2 milligrams per hour. We'll give him some acetaminophen, and we'll avoid NSAIDs in this patient just because it was an extensive vascular procedure. We don't want to potentially risk any bleeding. So I'll go through a quick summary of the procedure as it was. We'll start off basically with when the patient entered the room. When the patient got in the room, we got the monitors on. We gave him midazolam 2 milligrams IV as well as fentanyl 25 mics IV to aid in insertion of the epidural and the art line. The epidural went in at T9, 10 with no issues first attempt. I helped the medical student with much guidance place an arterial line in the right radial artery. It transduced very well, it drew blood very well, it functioned very well for the whole procedure. The induction went very smoothly. The patient was easy to bag mass ventilate. However, he ended up being a grade 2B view with burp. He was more anterior than the airway exam had revealed. Post-induction, we had the patient on 0.8 Macasivo. We also then gave 2.5 milligrams Epimorph. So during the cleaning, prepping, draping phase, prior to surgical incision, the patient's blood pressure remained pretty labile. We ended up having to start a fennel infusion at 30 mils an hour to keep a systolic of greater than 100 and a MAP of greater than 65. Once surgical incision began, we weren't really able to wean the phenylephrine down. We still needed to maintain it at 30 mils an hour to maintain that MAP goal of greater than 65. Dissection down to the aneurysm was without complication. However, mobilization and further exposure revealed the aneurysm also progressed into the right iliac crest, so the surgical incision actually extended into the right groin area. Once he continued to dissect down further into the groin and mobilize the aneurysm, the fennel infusion was no longer enough to maintain adequate hemodynamics, and we initiated a norepi infusion via the central line at 4 mics per minute. Prior to cross-clamping, we administered 3,000 units heparin IV for thromboembolic prophylaxis during the cross-clamping period. The patient's hemodynamics did not warrant prophylactic nitroprusside for treatment of the cross-clamping hypertension. In fact, we ended up having to run the fennel and the norepi at 4 mics per minute, even while the cross-clamp was on. Total cross-clamp time for this procedure was 1 hour 10 minutes. Very reasonable average time, and well under the kind of threshold of 120 minutes or 2 hours. During cross-clamp and grafting, the patient lost an estimated 1.5 to 1.75 liters of blood. Unfortunately, we do not have cell salvage up here at UH Embassy yet. We then had to run serial ABGs to assess hemoglobin and metabolic profiles, as the lab is unfortunately quite slow with doing this. We brought the primed and prepared level 1 in to the room and proceeded to give the patient, over the course of the next 40 minutes to an hour, 2 units of PRBCs, an amp of calcium, a unit of PRBCs, 1 unit FFP, 1 amp of calcium, 1 unit of PRBC, 1 unit FFP, 2 amps calcium, and 1 amp of sodium bicarb. While continue to run basically serial ABGs. At this stage, I feel like Rotem would have been very useful. Unfortunately, the lab doesn't even have it up here. This particular day of the surgery, the blood bank only had 2 units of cryo and 2 units of platelet available for the whole hospital, so we were trying to be quite judicious and not using them. Given the equipment and blood bank limitations, I feel like the particular transfusion interoperatively was quite balanced overall. So once the patient was satisfactorily hemostatic and the surgeon began to close, we then gave him 20 milligrams Lasix to aid in renal protection post cross-clamping, since it was an infrarenal AAA. So prior to skin closure, we did another ABG. It was very satisfactory. His metabolic profile was normal. He had a sufficient hemoglobin, and we were actually able to wean the norepinephrine to 2 mics per minute and had the fennel completely off. We proceeded to comfortably extubate the patient and transferred to PACU, for where he spent the nights with no issues, and the next morning was transferred up to surgical step down. In total, the surgical time was 6 hours. The patient lost about 2.5 liters of blood. He received 4 units of red blood cells, 4 units FFP, 2.5 liters Ringer's lactate, and 4 liters of normal saline. His total urine output was 830 mils for the entire surgical procedure. Thank you.